1,540 fatalities from car wrecks in 17, the last year we have the numbers, and 1,537 overdoses that we know of. And of course, lots of drug overdoses are reported as suicide or some other reason, and so we think they're grossly underreported. Numbers went up from 16 to 17 by 10%. It is a major problem. The movie is heart-rending. If you're a parent or a grandparent, the father has written a book called Clean. It's by David Sheff, S-H-E-F-F, and I would recommend that anybody read it. It's called Clean. It talks about our system, but it's very easy to read. Talks about some of his son's trials and all, and his journey in trying to find the right kind of help and how we can change and what we need to do to help more of our people that are addicted. So I can't tell you enough. I have to thank everybody in my committee that voted for some of the tax breaks for our in movie industry. Amazon Pictures was nice enough to do a private screening for me last Wednesday in my district. For people in my community, school people, people that worked in addiction, people that are addicted and in recovery, and had a packed house. And I think it started a discussion because Cobb County, out of that 1,500, had 335 deaths. We are the #1 county in Georgia for overdose deaths. So I'm very appreciative of Amazon Studios that did that for me. So that's my commercial for a beautiful boy. Don't go to the other one. It's boy something else, and it's really terrible. So I will tell you that to do that. We also have a new policy analyst sitting by me, Michael Polachek. So my intern this season, Harper, stand up, is Harper Melnick, if you need her, another Cobb County and at Georgia Tech. And of course, Kim Shirk. And Kim, come on up and go over where you're supposed to be. So is back again with me. So please feel free to talk to any of the three of them. And of course, we have Lynn back and Betsy. Yay! And Betsy, you have a new lawyer with you. You'll introduce him?
Yeah, sure. This is Vince Weekend in our office. He's going to be doing insurance and being also helping with healthcare and education.
Okay. Yeah. You didn't get small things to do, did you? just the big committees. Okay. Also, to my committee members, to get started, there is a legislative dinner. Come on, Demetrius. Just, pile in somewhere. You're welcome. We don't mind.
Thank you, Madam Chair.
I mean, you just get 10 lashes with a wet noodle for being late. I'm glad to have you back. Okay. As some of you may know, Georgia State and their health policy division has for several years put on courses for representatives and for our staff on learning and trying to realize the need for a systems approach to passing healthcare policy. So that we realize that sometimes when it's like a bucket that's leaking, if we plug up the hole here, if we're not careful, it just, sprouts another hole in the other side of the bucket, and to have us look at what we do in a more systematic manner. The Woodruff Foundation, which usually only funds things for 1 year, has funded our program, or their program, about the 4th year. This may be the 5th. We have about 4 other states that have copied the program, and we were invited to Washington, D.C. to talk to staff up there about the program. So they are putting on this legislative dinner. It is tomorrow night, we're on Tuesday, Wednesday at 5:30 to 9 at the Commerce Club for members. If you want to attend, you can get more information. If you can tell us today, that would really help. And it will not just be a dinner, but there will be a discussion about waivers. There are 2 different kinds of waivers. We've heard talk about the possibility of moving forward on waivers, and this will be, in their manner, just a frank discussion, not saying how we should go or anything, just about what the difference in the waivers are. So if you have not already signed up and want to attend, please let Lynn know. She's here too, I think, Lynn. My administrative assistant is here, and when you get through with the program. Okay, with that, we'll get down to business, and then we have a presentation. And it seems like, let's see if I got it. I have a bill to present. I am going to go to the well, and I'm going to let my new vice chair see if he's as good as running a meeting as he is a doctor in the emergency room. And, okay, Representative Newton. All right, will you keep him online, Representative Reiner, since you've done this before? And let's see, do we have Margie here? Margie, you want to come up to the front, right here at the table? Pull up a chair, and I'll join you down there.
Should my army join me as well, Sharon, or just me?
Pardon?
Just my army?
Well,
Okay.
you travel in pairs? No, it's all right. Now pull your chairs over by the table.
Who do I call on first? Who do I call on first? Who do I call on first, Chair?
We're going to get there.
Okay.
Thank you.
We got anybody else?
Nope.
Well, this is only part of Margie's army. This is Margie. And she has breast cancer. She's in remission. She's still getting treated. And she has started a movement to make a difference and to make a change in the way that women are notified after their mammograms. So this is, I'm bringing you the substitute to House Bill 62. Basically what this does for women with dense breast tissue, and I could probably ask a whole bunch of the ladies on this committee if they have dense breast tissue, and turn around and ask the audience, and we would probably have it about half and half of the ladies here have what's called dense breast tissue. When you have dense breast tissue, it makes it very difficult to see abnormalities. This has been especially true with the old types of mammograms we have. There is now a new type of mammogram which has become much more available across our state, and it's a 3D mammogram, and the difference in the clarity in what you can see is amazing. The bill doesn't require that anybody have a 3D mammogram. It just says that when the radiologist sends out a report after the woman has had her mammogram, that if she has dense breast tissue, that she's told in that information that dense breast tissue is more difficult to detect, and it also may increase your risk for breast cancer. That is the latest research, that actually having dense breast tissue may increase your risk of having breast cancer. And that given that information is so they know more about their options, and that they have the right and, will perhaps feel the need then to discuss with their physician if any more treatment is needed. It's simply a notification that goes out with the report. Not every woman that has dense breast tissue will need any kind of other exam, but there will be some that do. And with that, I'll let Margie briefly tell you why she thinks that it is so important that we pass this law, which is titled Margie's Law.
Can I read all
Do you want to read? Not
Yeah.
all 3 pages.
Thank you,
Tell it
Chair.
in your own words. You can do it
very
just
good,
fine.
very good. Good afternoon. Thank you all. Thank you, Madam Chairwoman, and members of the committee for having me today and listening to what we have to say about Margie's Law, and hopefully we're going to gain your support today. I am a mother, friend, sister, aunt, niece, daughter, and when I turned 40, I did my mammograms like every other woman, and everything came back clear on my mammogram report. Clear, no concerns. Great. I went on my merry way and did my thing. When I was 44 years old, I had my annual mammogram in August of 2018, And again, actually I felt a lump on this side, and at that time they ordered a 3D mammogram, which is the latest technology for women to examine our breast. Everything came back clear, no concern, it was just a cyst. Again, I went on my merry way. 6 months down the road, February of 2018, actually the mammogram was August of 2017. February of 2018, I felt a lump on my right side. And this time it was sore to the touch. And I thought, goodness, what in the world is going on? So I, of course, went to my doctor. This time she ordered a 3D mammogram with an ultrasound. That same day, I found myself going to the radiologist or the imaging center. Again, 2 different 3D mammograms were ran that day. One in the morning, then an ultrasound in between, and then another mammogram on that afternoon, because the ultrasounds showed something different than the mammograms had picked up. The next week, I found myself in my breast surgeon's office telling me that I had stage 2 breast cancer. I had a 3.6 centimeter tumor right here that had already spread into 3 of my lymph nodes that was consistently missed by 3D mammograms. Of course, I'm in the medical industry, so I thought, how in the world does this happen? I did everything that I was supposed to do. Lo and behold, I had dense breast tissue. The surgeon said, Margie, you have dense breast tissue. Trying to find your cancer is like trying to find a golf ball in the middle of a snow blizzard. You're never going to find it because it looks just like dense breast tissue. The only thing that picked it up was the ultrasound that was ordered additionally, or an MRI. So as you can see, for women with dense breast tissue, a 3D mammogram is not enough. And 40 to 50% of us are walking around, like Sharon said, or Representative Cooper said, with dense breast tissue. Every day, and of those women, a mammogram, a 3D mammogram, and these are national statistics, is missing a breast cancer. Of course, I did a lot of research, being in the medical industry. I'm like, how could this be? How could I miss this? How could I not be told? I've been in medical for 20 plus years. I did some research. I looked for reputable centers across the nation, whether it be MD Anderson, reputable associations, whether it be NCIB, the National Radiation Association. Then I found that there's been already 36 states that passed a law telling a woman what dense breast tissue means on her mammogram, telling her that if you have dense breast tissue, you're automatically at 4 to 6 times risk of having breast cancer, telling her that you can benefit from additional screening, whether that be an ultrasound or MRI, educating that patient and giving her that choice to make to prevent herself from going through cancer. So of course, it's already too late for me in that regard. I've already struggled. The last year I've spent 6 rounds of chemo, 25 rounds of radiation, double mastectomy, reconstruction, lymph node dissection. I'm still in, every 3 weeks I go for my maintenance treatment. I still have to take a daily chemo pill to prevent recurrence for the next 5 to 10 years. I'm on this constant, this has robbed me of the life that I had with my child, my husband, my family. My mortality has been lessened because of this, but something that could have been easily prevented had someone educated me and gave me that choice to have that extra screening and left that up to me. I'm not here today for me. I'm here today for all the other women, my sisters, my daughters, my friends. Please, we ask you to please support making awareness a reality in Georgia and every state, Margie's Law, so we can educate women across Georgia to prevent them from having to go through and losing their lives. Most recently, my wonderful friend Nancy Capello that led the charge in 36 states since 2009 to get this law passed. She just lost her life from a secondary cancer in November. So this is kind of for her as well. That could have been prevented had we had the knowledge to make this happen. So thank you in advance. Please, this does not affect just women, it affects men, everybody, your sisters, your moms, your aunts. Please, we just ask for your support in passing this law. Thank you.
Thank you. There's not a better person or advocate for women across our state of Georgia about breast cancer. In America, we have a tremendous rate of saving lives with breast cancer into the 90s. We can make it even in the higher 90s with more education and awareness for women. So thank you for all you do, and I would ask for the committee's favorable approval of this bill, and I'll be glad to, and one of us will answer any questions that you have.
Chairman Cooper, thank you for your presentation, your bill, and Margie, thank you so much for sharing with us. We do have some people with some questions for you, if you don't mind.
No, it's fine.
We'll start with Representative Drenner.
Thank you. Thank you for your courage to be here today. My question, as I was following your story, many of us now have gone on and had 3D imaging.
Yes, ma'am.
And then we leave thinking that everything is, good to go for another few months. And Madam Chair, I'm just wondering, this is a great bill and I could completely support it, that many of us didn't know that 3D imaging did not catch breast cancer. So my point is that this awareness that you're doing is outstanding, but is there not some language that we could say additionally that would note to us and our family members that have dense breast tissue that you may not be good to go?
Well, I think that the reason that we didn't, and we discussed this over and over again, is because the 3D does pick up a lot of them. So it's just not infallible. And so that's why you see that in the bill it says you need to talk to your physician. We don't want to scare women across the state that says right away when you get this you have to go have another exam. But we want them to talk to their physician who knows best whether after seeing it they should get even the sonogram. And that's why we left it out. And this has, and I think Becky Riles is here, can say, we've had some of the latest female radiologists that specialize in breast cancer go over the bill very carefully to see if it fits in with what's known scientifically at this point.
Representative Douglas.
Thank you, Mr. Chair. Thank you for your courage, first of all. Thank you for being here today. I just have a few questions. I read through the bill. Help me understand this, because I have a house full of women, so I need to understand what this is. Yes, even me too. So when you go get your checkups, your mammograms, or what have you, do your physician indicate to you if you have light tissue or deep tissue? Mm-hmm. Is that anywhere they indicate that to you, or do you have to ask for that?
You do. Would you like for me to?
Well, I think when you normally, now y'all can correct me if you do it differently, because I just had a mammogram back and I have dense breast tissue, is normally when you go get a mammogram, the technician does it. And unless you've had an issue before, most of the time you don't see the physician at that time. Okay. The technician does the mammogram, and then you wait for the radiologist to read it, and then you get the report back. And it would be at that point that you would.
So I'm sorry, I'd like to speak to that a little bit. So my background is in healthcare as well.
Okay.
And working in primary care, where a large number of mammograms were ordered. So the process is normally the physician will order the mammogram, the patient goes in, as she indicated, the tech does the test, the radiologist reads it, that report goes to the physician, who then someone in their office communicates to you, you're good for the next year. They don't send you a copy of your report, so it may be noted in your report, but you don't know that because you got the notification, you're good. And then the radiology center will also send you a notice to say, you're good. But the language that we're asking for is that when that radiology report comes out, that it clearly states what your breast density is, okay, and then what the higher risk factors are for you as a result of that dense breast tissue.
Okay.
Thank you. Representative Bennett.
Thank you, Mr. Chairman, and thank you, Madam Chairman. when we first started, I was only going to make a comment, and now you've prompted a question.
Okay.
So the question is pertaining to what Madam Chairman said. After the test is done, they give you a piece of paper that says negative. Is this to make them go a step further to say that you do have dense tissue?
Right. You wouldn't get it right after the test. You know, the technician does it, then the radiologist reads it. Like when I had mine, I went from a different provider. The old provider had used the older mammogram process. So they had to wait on mine because they saw something on the 3D and they had to wait to be able to compare them. So I got a letter saying, we're having to wait on your records to come to make a comparison, and didn't say anything. Then after they had the comparison, you get the letter that says whether you're okay or not. At that point, when you get that from the radiologist, it would include this language as
Okay.
it is in the bill.
Thank you. May I make my comment?
Sure.
Let me thank you so very much for this. This is so very near and dear to my heart. 57 years ago, my maternal grandmother passed from breast cancer, and I annually conduct an event called the Emma B. Allen Pink Sash Parade to increase the awareness about breast cancer. And so I do concur and would be honored to vote yes on behalf of Emma B. Allen, because I do believe that education and early detection does save lives. And I appreciate this, and I would even like to even take it a little further so we can talk about that. So thank you so very much, Ms. Margie.
Thank you, Representative, and thank you for doing that in your district every year for women.
Thank you, Representative. Representative Silcox.
Thank you, Mr. Chairman. And I thank you also, Margie, from the bottom of my heart. I am a childhood cancer survivor, and so cancer is always kind of a fear in the back of my mind, and I did have a false positive on my mammogram several years ago, and they did tell me that I had dense breast tissue, and but for that knowledge, I wouldn't have had further testing, and praise God, it turned out to be negative, but I think this is really needed, and again, just thank you. I think this will help women all over Georgia.
Thank you. Representative Hutchinson.
Hi. I wanted to say thank you as well. That's an amazing story that I'm sure have all of us thinking twice. I just had a question. Do we know if insurance companies are covering multiple mammograms, the regular one, the 3D, and the multiples that you had to endure?
You can speak to that one, because I can tell you, I didn't know about mine until they paid for it. So, I mean, I think it probably goes for whichever company that you're with.
So the general rule on that is that your first mammogram, a screening mammogram, is covered by your insurance company. If they find something that's suspicious, that would generate a diagnostic mammogram, and that is also covered by your insurance company. In terms of advanced screening, so once you are notified that you have dense breast tissue and there may be a reason for advance, in Margie's case, that would be covered because there was something suspicious. She had a lump, so that's diagnostic, and that would continue that diagnostic, and so that's generally covered. If you just as a patient, depending on your plan, as you said I have dense breast tissue, I'd like to have an additional ultrasound screening, in that case you likely would have to appeal, so that depending on the plan you would write an appeal, and then they would look at what your genomic testing is and what your risk profile is. If your mother or your grandmother or someone in your family had that, then generally speaking insurance companies pay that.
Chairman Ryan. I'm sorry.
Thank you, Mr. Chairman. At the appropriate time, I'd like to be recognized for due pass as a good first step.
This is the appropriate time.
I move due pass.
Have a second? If so, I have a motion and a second on LC 337655S. All in favor, say aye. Aye. All opposed, no. And the measure passes. Thank you, ma'am.
Thank you very much, members of the committee. Thank you very much.
Margie, thank you.
Okay, y'all don't leave.
For all the committee, Margie does have packets for us with additional information, so if you'll check it, maybe she's going to pass them out now. Thank you.
So Representative Choke has showed up for a minute, and now he's gone again. Welcome back to Health and Human Services. I know I'm really bad. Thank you again to the committee for the passage of that bill.
Madam Chair, I was just mesmerized by the vice chair. That he let it be known that that's the first time he had ever chaired any kind of committee. And the restraint that this committee showed by not asking about code sections or anything else, just what a great job.
Well, they cut him a little slack, and I'm so glad nobody else had any other discussion afterwards. We got that, so they didn't give him a hard time for not asking for any further discussion. So we'll give him a slack. You did a good job. Thank you very much, Mark. So as you can tell, we get intense in here, but we try to have a good time. And Representative Reiner sort of led the good times for so long, so we may have to find somebody else that has his sense of humor to add to it in the future. Okay, I think that many of you are familiar, at least by name, with our community service boards. They've been talked about a lot in the last years, and they do a lot of good in our communities, and they asked to come and make a presentation for you. So right now, we're ready for that presentation. Who's going to do it? Identify yourself and where you work, and then we're ready to go.
Yes.
Yeah, there we go.
Let's get to the right place here. Okay. Well, thanks, Madam Chairman and committee members, for the opportunity to share my passion for improving the lives of individuals with mental illness, addictive disease, and intellectual or developmental disabilities through the safety net of the great state of Georgia and your community service boards. Today we will discuss how we can work together to improve our health outcomes. Joining me today are Robin Garrett and John Powell, leadership of the GACSB, and David Kidd, president of the association. I have the honor and privilege of presenting today as the chair of the Public Image and Policy Committee and CEO of a member agency, Avita Community Partners. My name is Cindy Levi. We will share our presentation and our slides with you following today's presentation. So, what is GACSB? Well, it's the Georgia Association of Community Service Boards, and the membership is 26 independent provider organizations. We are located in 6 regions that are designated by the Georgia Department of Behavioral Health and Developmental Disabilities. If you visit our website, www.gacsb.org, you will find a map resource that is available to you, and that map is interactive to be able to identify and locate services across all 159 counties of the state. So, what is a community service board? Well, CSBs are an integral and essential part of Georgia's public system of care for behavioral health and developmental disabilities. We're the public safety net for behavioral health and instrumentalities of the state. To give you an idea of the state-level organization of its public system of care, this map shows that the state is divided into 6 regions, which are subdivided into 26 different catchment areas. As you can see, CSBs are statewide. It's a statewide network serving all 159 counties of Georgia. My CSB, Avita Community Partners, serves a total of 13 counties in Northeast Georgia, Banks, Dawson, Forsyth, Franklin, Habersham, Hall, Hart, Lumpkin, Rabun, Stevens, Towns, Union, and White. We are in Region 1 area of DBHDD. House Bill 100 in 1994 transformed the community mental health programs in the state of Georgia and moved from community mental health centers to community service boards. Also declared CSBs to be governed by local boards and be funded through contracts with the state of Georgia. And the Department of Behavioral Health and Developmental Disabilities oversees our delivery system. And believe me, through our performance monitoring reports, they make sure that we're following all the rules and policies. So how are we governed? Well, we are governed by a board of directors. Each CSB has its own board of directors appointed by the county commissioner or commissioners of the counties that we serve, along with elected or appointed officials. The majority of board members must be consumers of services or family members of consumers. For example, as I mentioned, Avita serves residents of 13 counties. So we start with 13 board members. Then we add 4 elected officials and 1 at-large member who is an individual in recovery himself. Add them all up, and we've got 18 board members, and they meet 11 times a year. So who do we serve? Well, we serve everyone, from birth on up. So we serve children, youth, and young adults, those with serious and serious emotional disturbance, other mental illnesses, substance use disorder, and more recently, autism spectrum disorder. So we're very pleased that Medicaid is now supporting services for individuals on autism spectrum disorder. Actually, the youngest one being served currently is 2 years of age. Adults, on the adult side, we serve severe and persistent mental illness with diagnoses such as schizophrenia, major depressive disorder, and bipolar disorder, and other mental illnesses, along with substance use disorders, individuals covered under the Department of Justice Settlement Agreement, also the Belton suit for deaf or English as a secondary language, as well as individuals with intellectual or developmental disabilities. Picture this. Your loved one is living with a severe and persistent mental illness, seeking a path to recovery from an addiction, or living with an intellectual or developmental disability. By a show of hands, how many of you would prefer that that loved one lives behind bars? Don't see any. So how many of you would prefer that they live their entire life in a hospital? Don't see any there either. So the CSBs really focus on providing services in the community. So the community is where services are delivered. The CSBs support the administration's focus on enhanced school safety. And we have mental health counselors embedded in schools as part of the APEX program to actively engage children and youth. The CSBs have the capacity to serve schools across all 159 counties in Georgia through the APEX program. Currently, we have mental health counselors in over 300 schools, with a goal of serving all Georgia schools. In addition, we provide training to school personnel and students to identify risk and warning signs in students and how to implement protective factors and engage them in treatment as needed. Examples are the Yellow Ribbon Suicide Prevention Program and Mental Health First Aid. I just focused on schools, but as you can see, really, we provide services anywhere within all communities. We also partner with many in our communities. You can see our sheriff's offices and police departments, our jails, our probation officers, our vocational rehabilitation and faith communities, our labor department and employers. Really, we partner with anyone any organization that is interested in partnering with us. So who provides the services? Well, we do have a staff of psychiatrists and nurses, licensed therapists, certified peer specialists. Those are individuals that are in recovery themselves. Board-certified behavior analysts, and paraprofessional staff. Georgia, like most states, continued to experience a mental health professional shortage of doctors and licensed practitioners alike. But the CSBs are fortunate to have high-quality providers on our team. And if we don't have one physically present in our office locations, we use technology via telemed to make certain that services are provided. As we look at the service delivery continuum of care, this is kind of a messy slide, just because there's an awful lot that is offered. But we focus on first providing the lowest cost and lowest intensity of service. And that would be through our core services or outpatient services. However, we provide every level of care on the continuum. I'd also like to recognize at this point, Madam Chairman, thanking you for sponsoring the 911 amnesty bill that is now in law, because we also are able to offer naloxone training. And I'd like to share a quick little story, because in our outpatient addiction programs, I had an opportunity to go into the group treatment and offer naloxone training to individuals that are in treatment for addiction themselves. In doing so, I also offered them some naloxone kits. Well, I'm very proud to report that one of those kits was used to save a life just a few weeks ago. So thank you. We also coordinate with community resources, all different resources. We provide coordination and linkage to comprehensive treatment, recovery, and supportive services. Our highest level of care is the Behavioral Health Crisis Center. Here we combine 24-hour-a-day, 7-day-a-week walk-in crisis intervention and counseling services with emergency receiving capability and crisis stabilization beds. So there has been a lot of talk over time about how individuals with either a mental health crisis or addiction are clogging up our emergency departments. And so this is an emergency opportunity for individuals to go directly to a behavioral health crisis center. Individuals who are experiencing the behavioral health crises are provided assessment, short-term crisis counseling, supportive services, and referrals for ongoing care. So what happens is individuals go 24 hours a day, they can walk into what we call a walk-in center. So if after an assessment they need additional support, then there is a 23-hour observation area. If they need further treatment, then they can move into the Crisis Stabilization Unit. And the Crisis Stabilization Unit provides stabilization to those individuals experiencing mental health crises or needing detoxification from substances. So we do detox in our CSUs from prescription medications, from alcohol and illegal substances. We can take individuals voluntarily or involuntarily, because we are a medical receiving facility. We do operate 20 adult CSUs across Georgia and 3 child and adolescent CSUs across the state. And one of our partner agencies, Viewpoint Health, is developing a CSU specifically for children and youth diagnosed with autism spectrum disorder. We also provide wraparound services. So residential supports, homeless services, employment, court services, and transportation. By the numbers, as you can see, over 5,000 individuals with an intellectual or developmental disability, 29,000 mental health and substance abuse of our youth, and over 144,000 adults with a mental illness or substance use disorder. So how are we funded? Well, as you can see, we have a variety of partners. 42% of our funding does come through our state contracts with the Department of Behavioral Health and Developmental Disabilities. Then our next largest portion is from Medicaid. Then we also have a variety of others, our in-house pharmacies, foundations, local, state, and federal grants, personal donations, as well as county contributions and private insurance and Medicare. Some of us also have contracts with the Veterans Administration. So our hope is to create a complementary treatment system. Please, we want to avoid creating parallel treatment systems. That's to no one's advantage. But if we all work together, then we can complement each other in our treatment and capitalize on evidence-based treatment systems practiced within the CSBs. Our headquarters for the GACSB is located in Douglasville, and you'll have that contact information. And you can also see us on social media. So thank you again for the opportunity to present this afternoon. And of course, we're open for any questions.
Thank you for the presentation. I'm sure we're going to have questions. I will say that your in-house units do a great job. We just don't have enough beds, especially for our people with addictions. And I will say that so many of the people with addictions, which is often overlooked, and one of the reasons they fail in treatment is because they have underlying psychiatric problems that go undiagnosed. And when they are treated for their psychiatric disorders, often find it easier to go through recovery and become clean. So, but for some reason, they just don't get tested, and those underlying mental health problems are often not treated. So, who we got? Is it representative? Who's at one? Who is it? Oh, okay. Well, you're recognized.
All right. Thank you, Madam Chair.
Sure.
Thank you for the presentation.
Yes,
I noticed you say you operate in certain areas at this time, North Georgia, but I was wondering, what is your relationship or protocol type with hospital, relationship, as well as like paramedics when they go out? What is the possibility if they go on a scene and you have someone that said, look, I'm in bad shape, I want to go to some type of rehab? What are you guys available? Can you kind of tell us about that?
I can. Thank you for the question. And yes, my organization that I'm CEO for is in Northeast Georgia, but the community service boards cover the entire state. So I just wanted to be clear on that. With regard to the question on how we interact with hospitals, as well as paramedics and those that are out in the field, we are an emergency receiving facility, so individuals can be brought directly to our crisis stabilization units or behavioral health crisis centers. We are very actively involved in crisis intervention training for law enforcement as well as paramedics. As far as the hospitals are concerned, we're in constant communication with our local hospitals. And one example, in a rural area, there was a Stevens County Hospital in Toccoa applied for a grant to address the opioid issue. And so we did receive a SAMHSA grant, a federal grant, to do that. And we are working as a collaboration within the community. So we're always in communication with those that are outside in our community.
Okay, well, thank you. That'll help address some of the issues we're having in a lot of the ERs being kind of backed up. So thank you again.
Yes, sir.
Okay, Representative Henson.
Thank you for your presentation. I'm in DeKalb County. If I'm not mistaken, ours is a county run.
It's a community service board, DeKalb Community Service Board.
Okay.
So it's part of our network. Yes.
It's part of your bigger network.
Yes,
but
it is.
Avita is a private company as opposed to ours, which is more.
No, they're all the same.
They are?
So we're all community service boards that were formed through legislation back in 1994. So DeKalb is the same as Avita, as far as that's concerned.
Okay, my question is, again, number of beds, which are sorely lacking, the time frame that a patient stays, and again, the funding from the state and the funding from the county. How adequate or inadequate is that?
Okay, so as far as the number of beds, we can always use more beds. And DBHDD has put in their budget for additional funds for expansion. So we continue to expand across the state, moving from the CSU, Crisis Stabilization Unit, to a full behavioral health crisis center. So I know in this budget year, the next budget year, Avita is going to be opening a new facility in Northeast Georgia, just a mile and a half down the road from Northeast Georgia Medical Center. So yes, we are always lobbying for additional funds as far as that's concerned. As far as what is the length of stay, the average length of stay in our crisis stabilization unit is 4.7 days. And I can also tell you that I just looked at the numbers this morning. They continue to grow as far as the number of individuals that are in need of detox or addiction services versus mental health. So when I looked at our statistics for our crisis stabilization unit, we now have 77% at the end of this last calendar year, 77% were being treated on the addiction side, and the remainder were behavioral health crises.
Okay. Representative Hutchinson.
Thank you, Madam Chair. I had a question. You mentioned something about not creating parallel treatment systems.
Yes.
Can you expand on that?
Sure. Well, for example, we have collaborated with the schools for the APEX program. So instead of the schools hiring their own mental health professionals, we are taking the mental health professionals into the schools. And so in doing that, it's more convenient for the children and their parents so that they can receive the treatment that they need. But also, if you look at, say, for example, if a school were to hire their own mental health professional, they wouldn't have the clinical supervision that community service boards offer, or the direct access to a medical practitioner in an APRN or a psychiatrist. So I was just referencing something like that. Of course, we have a contract with the state to be the state safety net. So our primary responsibility is for those that do not have insurance or those that have Medicaid. So there is still a very big need for other practitioners in the communities that primarily focus on commercial insurance.
Representative Silcox.
Thank you, Madam Chair. I enjoyed your presentation very much, and I guess first of all I want to just ask, do you think that the proposed budget that the governor has proposed in terms of increasing the funding and number of mental health counselors we're going to have statewide, the APEX program, do you think that will be enough?
Well, as far as the expansion, I know that the focus is to have mental health counselors in all high schools. When the APEX project began, it was any school. So I can tell you that we have mental health counselors in elementary schools, middle schools, 9th grade academies, and high schools. But we have to start somewhere. So having a goal of having mental health counselors in all high schools as a means to address school safety is a great start.
Great. And I wish we had a CSB, but we do not have a CSB in Fulton County. And I know that's a complicated history because of Grady. But I would say that our crisis needs are huge in Fulton County. And we are hoping to have some more crisis centers, particularly given the length of our county, because it's such a long county. Right. We really just have Grady, and that's difficult for people either on the far southern or the far northern end of the county.
Yes, and one of our community service boards, River Edge, is working with Fulton County, providing some consultation and support.
And Chris 180.
And
yes,
Representative
and Chris
Silcox.
180, correct.
I would like to see the counselors in all the schools, especially as it relates to drugs. They are finding now the earlier the intervention, and I was amazed to attend something that the Boy Scouts of America did in our Atlanta region, and one of the breakout sessions was on early identification with children with problems, and how relatively easy for a professional to recognize early problems in the primary settings when they know what they're looking for, and to have early intervention both for drugs and for other behaviors. So, I mean, I know why they're putting them in the high schools, but I would hope that we would soon have them in all our schools, including our elementary schools, so we can start early with prevention. Representative Hogan.
Madam Chair, I appreciate your presentation, but there's one area I think that you need to really concentrate on community service boards, and that's our jail population.
Yes, sir.
The jails are no place for individuals who have substance abuse or mental health. Down in Glenn County, we have anywhere from about 50%, from 30 to 50% of the people in the jail carry a mental health diagnosis. We've hired a full-time psychiatrist, and also the psychotropic meds run anywhere from $175,000 to $200,000 a year. This is statewide, the problem we have in the jails. It's no place for people to be with mental illness or substance abuse. When 1994, when we moved all the people out of the institutions, they wound up a little bit later in our jails statewide. Also, the state jails are full of them too, and that's no place for them to be and to receive the abuse that the mentally ill receive in the jail population. Our sheriffs are trying to do a good job, and they're frustrated with it. I talk with all the sheriffs just about all the time about the problems they're having. So if there's some way we can improve the community service boards working with the sheriffs and the jail population, I'd appreciate it very much, because that is a needed area, and I see that as the most needed area in this state for mental illness right now.
Yes.
Thank you.
Thank you very much.
That was our last question. So I'd like to say thank you very much for the informative presentation. I thank the committee members for paying such close attention to it. Don't forget, if you want to attend the dinner tomorrow night, would you please let Lynn, my secretary, know as we adjourn. Here again, remember, it's a seated dinner, and so if you're going to RSVP, please show up, as your mama would have told you to do. And with that, and I forgot about, we do have the joint meeting tomorrow morning at 8:30 with Chairman Ballinger's Committee on Juvenile Justice, Education, Health, and Human Services for Children. I think it'll be very informative, and will you try to make every effort to be there? I know 8:30 is early, it's for me, but I will see you in the morning to those of you that can attend. Take care, and thank you very much. We are adjourned.